I am Dr. Maria Piedad Rosales Natividad, Dr. Apichi. I was previously the head of our Stop Asthma program at the UST Hospital, and I will be chairing as well as moderating this convention symposium. So meanwhile, may we remind everybody to scan the QR code that is flashed on the screen, make your attendance count. So this is our breakout session entitled Multidisciplinary Discussion Treatable Traits in Asthma. But allow me please to start with a case presentation. Case? All right, please give us our slides for the discussion. This one. There you go. Okay. Medyo putol, kaya hulaan nyo na lang yung nasa side, ha? Ayan, ha? Ayun, okay. We have a 35-year-old male. He has been manifesting with recurrent wheeze, shortness of breath, and chest tightness. He said that he was diagnosed with asthma even as a child, and his latest medication is budesonide formoterol, which he takes 2 puffs twice a day as maintenance, and then he nebulizes with salbutamol as needed. He claims also, and this should always be in quotation marks, good adherence. In 2023, he had 3 exacerbations, for which he had to take short course of oral steroids. He had 5 ER visits and eventually was hospitalized once. And in this past month, he has been having chest tightness, shortness of breath. He also hears wheezes. Now, multiple times in a day, he nebulizes with salbutamol. He says also that he has identified some of his triggers: mold exposure, exercise. That's why he doesn't like to exercise whenever he has upper respiratory tract symptoms, as well as humid weather. So, past medical history: he has had pneumonia 3 episodes in the past 10 years. He was diagnosed previously and treated with gastric ulcer and a Mallory-Weiss tear. He self-medicates though with omeprazole. He has atopic dermatitis, allergic rhinitis, for which he takes a fluticasone nasal spray, loratadine, and Montelukast. He had functional endoscopic surgery twice, sinus surgery twice, once when he was at 7 years old and another when he was 28. He was treated for TB, complete treatment, when he was 25. He also has impaired fasting glucose. So particularly when he has to take oral steroids, his CBG goes up. He also has shellfish allergy. Personal and social history. He used to smoke 5 to 10 cigarettes a day, but he cut it down, he says, to about 1 to 2 cigarettes per day since 5 years ago. He is an environmental engineer, and he works outside. He works outdoors. He has a pet dog at home. Okay. Physical examination. He is not in distress. Vital signs are stable. He doesn't have fever, but his BMI is 31.14. There's no active skin lesions. HENT, there is enlarged turbinates, but no tonsillopharyngeal congestion, no lymph nodes that are palpable. Cardiac exam seems to be okay. Auscultation of the lungs, there's diffuse wheezes over both lung fields. Abdomen is globular, no tenderness, organomegaly, no pedal edema. Neuro exam is essentially unremarkable except for the depressed state or depressed mood of the patient. So these are just some of the labs that were done. V1, VC is very much decreased, but post-bronchodilator, there was complete reversibility. X-ray as well as CT scan showed some calcified nodules. IgE is high, and it is positive to dust mites, dogs, and cockroach. CBC also has increased absolute eosinophil count, significantly increased. So our patient, he claims to be he claims to have good adherence to his medications, and yet he still remains very, very symptomatic. So what are we going to do? Should we step up therapy? And in many instances, that is our instinct because we are so focused on this stepwise approach that we have, that GINA has been recommending for the past many years. But are there other options? And this is where we will now discuss the other treatable traits in bronchial asthma. Again, it's a multidisciplinary discussion, objectives of which are, number one, we will introduce the treatable traits and separate it from the stepwise approach. Let's not forget those steps, but there are other options that we can have. And this is where we will discuss the pulmonary as well as extra-pulmonary factors and conditions that can impact asthma control. And finally, we will try to determine if this kind of approach can be applied at the primary care setting. And so I will have some lovely ladies to help me out. Siyempre, lovely ako, lovely din sila. Match kaming lahat. So may I call first our ENT specialist, Dr. Cecilia Gretchen Navarro-Locsin. So she is currently a professor at St. Luke's College of Medicine and is the head division of surgery at the PCMC. Our second guest lecturer will be Dr. Geraldine Claire Floro-Lucero. She finished her fellowship training in adult gastroenterology, clinical nutrition at the University of Toronto and fellowship in training in gastroenterology at the UP-PGH. And our third guest lecturer will be Dr. Jannel Gatlabayan-Cleto. She is a section head of the Consultation Liaison Psychiatry Department of Psychiatry at the Medical City. Ladies, can you join me up here on stage? Let's give them a round of applause. All right, so we will be discussing, again, our asthma treatable traits. And we are so focused on the stepwise approach. A lot of us have memorized this, but many times we just go from step 1 all the way to step 5, forgetting that there is something above this step ladder that we should also pay attention to, and this is the circle. What is in this circle? We have to always, of course, our patient is already confirmed to have bronchial asthma, he has spirometry already, but there are other things that we have to pay attention to before we go to the steps. And these are, you have to look at the modifiable risk factors, the comorbidities, technique and adherence, and then of course the patient preferences as well as what else he needs, no, to be able to control his asthma. And these are some of the treatable traits that we have in bronchial asthma. These are divided into pulmonary, lifestyle and behavior, and then the extra-pulmonary. So we will be discussing the ones that are associated with our patient. Let us take first the pulmonary traits, because I'm the speaker now. I will give them the microphone later. So we will be touching on those with the yellow arrows. And you already know me, I already was introduced, and we will focus first on inhaler technique. And this is the saddest part, because when we prescribe inhalers to our patients, we presume that they are taught the proper way to use these inhalers. Sometimes they're not. And so this is one failure on the part of the physician. We have to spend time with our patients, teaching them the proper way to use the inhaler. All of us are familiar with this episode of Dr. House, where the patient kept complaining that she wasn't getting any better in spite of taking 3 inhalers, going through 3 inhalers in a week. And when Dr. House asked her, "Show me how you use it," she brings it out and starts spraying it like you would perfume. I haven't had anything this extreme, but I have had a patient who also complained that she wasn't getting any better. I asked her to show me how she used the inhaler. This was one of the dry powder inhalers. So what she did was, "Doktora, ito, binuksan kong ganyan, tapos huminga akong malalim." I expected her to say, "I exhaled next." No, she took a deep breath, put that inhaler in her mouth, and then ginawang big flow. Siyempre, hindi siya gagaling. Bilino out niya yung powder. And I teach. This is the saddest part. I always teach. And so imagine if you don't teach them, where are our patients headed? So these are just some studies that said that there are errors in inhaler techniques for both COPD and asthma, but particularly the MDI, which all of us love to prescribe. These were more common among asthma patients and female gender, as well as shorter duration of the disease. Inhaler technique, how does it relate to patients' preferences and attitudes towards their inhalers? The conclusion again stated that the majority of the asthmatic patients did not use their inhalers correctly because there was a lack of understanding of the importance of the correct technique in asthma control. Many times these patients, when they become symptomatic, they inhale their short-acting beta-agonists, and there is some relief, although not complete control, there is some relief. And that makes them believe that they're using their inhalers correctly when actually they were not. So these are some of the different steps in inhalation therapy. So for inhaler therapy, you look at all of these. If this is what the patient has to follow, he is going to be very, very confused. And you can see in that other table that there are a lot of problems with the different steps, particularly the full expiration, the coordination, the slow deep inspiration, and the breath holding. So we have to instruct the patients properly for them to maximize the efficacy of their inhalers. So incorrect inhaler technique is still unacceptably high. And this is the real world. It's different from clinical trials where the patients are monitored. This is the real world, and unfortunately, most of our patients are in the real world and not in clinical trials. And it has not improved over the past 40 years. And it is a major obstacle for achieving good asthma control. So, conclusion, what are we supposed to do as physicians, whether in primary care or in the specialty? We have to follow up repeated checking of the patient's inhaler technique and correcting the patient each and every time. So how would I manage this part of the treatable traits? Let's follow what GINA recommends. It is always to check the inhaler technique, and if you get GINA, it's each time the patient visits. Not just once or once after 3 months, each time the patient visits. Now, you may also ask your patients, go and review proper inhaler technique. There are websites for this. This is PCCP has coordinated and put up these videos that your patient can take a look at so that they will have correct inhaler technique. So teach them, give them a copy to this link, give them a link to this particular website, and have them register so that they will always be reminded of proper inhaler technique. Next, let's take a look at airflow limitation. Our patient had a very, very low V1 VC, 48%. But if this is the case, the patients who have a very low V1 VC are always at very high risk for exacerbations. Let's take note, though, that there was complete reversibility after giving bronchodilator therapy. Remember also that in the past months, when before the patient consulted, he was already becoming very, very symptomatic. So what does this thing tell us? Again, it may be just because of poor inhaler technique or adherence, which will be also discussed later. Let us keep checking whatever gadget the patient is using. We have to make sure that he is using this correctly. It's mind-blowing, right? Because it's something that we should be teaching our patients, and yet many of them still don't get how to use the inhaler properly. So always go back to that. Next, we will discuss eosinophilic inflammation, which our patient has. This is more for the specialist, no? But I will just mention it briefly now, just so that those who are not in pulmonary medicine may be a little bit more aware that something like this does exist, because patients with a high eosinophil count are at higher risk for exacerbation. So what happens when there are eosinophils? These cells accumulate at the site of allergic inflammation. They release mediators. They contribute to the development as well as worsening of bronchial asthma. They have a role in airway remodeling, so they're important in terms of this patient will probably go into frequent exacerbations. So how do we diagnose this? You can do pheno, sputum eosinophils. I don't know if we have any institution though in the Philippines that has this. Blood eosinophils, we just compute using the CBC. The treatment approaches are quite more for the specialists, steroids, leukotriene modifiers, as well as biologics. So if you do have a patient with a high eosinophil count and with uncontrolled asthma symptoms, then please just refer. Because these patients need more intensive monitoring and some of them will need biologicals. So this is not anymore for the ordinary, for the primary care setting or for the internist. Maybe just refer to the pulmonologists who are here. Dr. Dean, ayan, nag-advertise pa eh. Let us also touch a little bit on infections as well as environmental and occupational diseases or exposure. Our patient says that every time he has an upper respiratory tract infection, he starts having exacerbations. Problem is, URTI symptoms very similar to allergic rhinitis symptoms, as well as your rhinosinusinusitis. This patient, at the time he consulted, did not have fever. He did have enlarged turbinates, which will be touched on in a little bit, but there was no tonsillopharyngeal congestion, no lymph nodes, there were no crackles that were heard, there was only diffuse wheezes over both lung fields. Chest X-ray and CT scan showed calcified nodules. He was treated when he was 25 years old to have for tuberculosis, and calcification means it's probably inactive and does not need to be managed. However, he does work outdoors because he's an environmental engineer and he has a pet dog at home. And remember, his IgE was positive for dogs. That's a problem. So how will we manage this patient? Complete physical exam. You look at the places in the body which mostly are correlated with cough as well as shortness of breath, the throat, and certainly the lungs. Okay? These are the sites of infection that mostly will trigger symptoms as well as asthma exacerbations. And then you go and ask about occupational, environmental, or other exposures. Maybe you can encourage your patient to wear a mask at work. We have a lot of patients in Pulmo, the casino dealers, who work in areas where there's a lot of people who smoke. We ask that if they be allowed to wear a mask. Some of them are not allowed because they have to show their pretty faces. But if they're allowed to wear a mask, or we can request that they be transferred to another area. So you can wear a mask at work, or you can work from home, kung pwede. The dog problem is another thing altogether, because I will never give up my dog. I'll wear a mask the whole day in the house. So that is something that you have to talk to your patient about. How to deal with this, because he does have sensitivity to dog dander. Okay, so these are just some of the pulmonary treatable traits. Remember, though, that the patient manifested with a host of other symptoms and problems and comorbid diseases. The patient said he had atopic dermatitis and allergic rhinitis. He had functional endoscopic sinus surgery. I'm not sure what the importance of that is. That's why we brought in a guest consultant from ENT at age 7, as well as at age 28. He also has shellfish allergy. On physical, he had, again, this international units, IgE, dust mites, dog, cockroaches, and the eosinophil count was increased, a very, very significant allergic component. So let us call in to discuss some of the extra-pulmonary treatable traits in asthma that are related to ENT. Can we call in Dr. Gretchen Navarro-Locsin?
So first of all, Doctora, thank you for referring this patient to us in ENT. The first thing I will ask is if, okay, sorry, that's backwards. Okay, there you go. So the first thing, Doctora, I would ask is, does our patient have allergic rhinitis? So in the first place, how do you know that any patient has allergic rhinitis? When you look at the 4 cardinal symptoms of rhinitis, this is going to be rhinorrhea, nasal obstruction, pruritus, and sneezing, okay? By themselves, these are going to be very non-specific signs of symptoms of your rhinitis. It can mean that the patient has allergic rhinitis or non-allergic rhinitis. But if this is also with the addition of your ocular pruritus, bingo. Chances are this is a patient with allergic rhinitis. And then again, I'm going to look at the conditions under which the patient develops this. Is it unilateral? Nope. That's not likely to be allergic rhinitis. Maybe you're looking at something structural, okay? Does the patient have facial pain? Does the patient have mucopurulent discharge? Then maybe you're looking at something infectious. Does the patient have recurrent epistaxis? Oh my. In the male population, maybe you're looking at a tumor. It's common to have nasopharyngeal carcinoma among our patients with epistaxis. All right, so what you want to do is you want to look at the other pathologies that may warrant a referral to another specialist. Then I'd like to go through a very, very detailed personal and social history. So again, in this particular patient, works outside, outdoors. So what you want to do is you want to take a look at the environmental, possibly the environmental triggers, whether it's going to be your aeroallergens or it's going to be pollution or anything else that will help us in diagnosing this patient. So clinical history, we want to go through our signs and symptoms. We want to go through a very detailed, again, personal, social, and work-related or school-related or home-related factors that will give us the triggers for this particular patient. Then I go through the examination. I just take a look at the patient. Does the patient have allergic shiners? Is there a crease because the patient keeps on rubbing his nose? Are there Denny Morgan lines? Okay, very suspicious for a patient with allergic rhinitis. I want to take a look at the nose. This particular patient had enlarged turbinates, so is this a structural problem, or are the enlarged turbinates due to the inflammation that is causing your mucosal congestion, okay? I want to take a look at the ear. On otoscopy, do I see fluid in the middle ear? Suspicious again for otitis media with effusion. So this particular patient, does he need to have his ears drained for the fluid? I want to take a look at the throat. There's no tonsillopharyngeal congestion, but he's got some cobbling. So what is the reason for the cobbling? Is it the allergies? Is it postnasal drip? Again, you may want to dig deeper. And then, of course, if the patient has wheezing, definitely that is a sign that you want to look at, okay? All right, so, okay. Unfortunately, a very detailed clinical history, even with your very extensive social and personal evaluation, and the PE, which to a large extent are going to be non-specific, are not going to be confirmatory of your diagnosis of allergic rhinitis. So you will need three things. First, you need a very detailed clinical history. Next, you want to get an idea of your exposure to allergens. That is why you do a very, very detailed history, because you want to know whether or not this patient has exposure to a suspected aeroallergen. And finally, you want to look at the sensitization of this patient to see whether or not indeed this patient is sensitized to aeroallergens. How do you do that? You do a skin prick test. You can have an intradermal test. You have the serum-specific IgE, and then you do a nasal provocation test. So for this particular patient, the specific IgE was very high for your patients with mite, cockroach, and dog. Okay, dog, that is going to be a little bit important. Well, we'll talk about it later on, okay? Nasal provocation test, some patients who have allergic rhinitis may not test positive when you take a look at your skin prick test or your serum-specific IgE. But if you were to do a nasal provocation test and you look at the secretions, the cellular and the cytokine profile is going to be exactly similar to the patients who will test positive. These are the patients who are known, who we call having local allergic rhinitis. So that's possible. Now, do all patients need to undergo this very extensive workup? So when would we recommend? Definitely, if you're not sure of your diagnosis, then a referral to a specialist is warranted. If you've started the patient already in pharmacotherapy and that this particular patient has already been on your nasal steroids, he's on an oral antihistamine and is on Montelukast, and assuming the patient is compliant, yes, this is another patient who warrants a referral. There's multiple organ involvement. We'll talk about that a little later. If I'm considering immunotherapy, and of course, if this is a patient with possibly local allergic rhinitis. We want to assess severity and frequency of the disease because this is going to impact on the way we're going to manage this patient. And when we're looking at the frequency, for example, does it occur the whole year round? Is it certain times of the year only, meaning is it seasonal? And then you want to take a look at the severity. How much impairment do you have in terms of sleep, daily activities, school or work, and therefore you will be able to classify the patient as having intermittent versus persistent disease, mild versus moderate to severe disease. How do you monitor? Ayaw? Okay, so how do you monitor in your clinic the symptom control of the patient? Remember, this patient was already on medications. Then you use a very simple visual analog scale or scoring system. It's from 0 to 10, 10 being the worst case scenario, most bothersome, 0 of course is not bothersome. So you look at the middle, 5. Where does the patient, and this is current, as the patient comes to your clinic, where does the patient fall? And the reason for this is frequency and severity of the disease will impact on how I'm going to manage this patient and also the prognosis of this patient. So if you take a look at the current guidelines in the management of allergic rhinitis, you're going to notice that we don't go anymore with those rigid, do this, do that. Because it's going to be a very patient-centered management. Meaning you want to ask your patient, where do you fall within this spectrum? If the patient's score, as you look in your visual analog score, is less than 5, then you can start with any therapy, oral antihistamines, intranasal corticosteroid sprays. If it's greater than 5, a score of 5, then you're looking at a patient who is most likely will need more than one therapy, will not do well with monotherapy, okay? So here you will see first is in a patient who is untreated and is symptomatic, okay? So most of us will start with oral antihistamines, that's fine. And then you monitor based on your VAS, your visual analog scoring system, then you monitor, should I step up? Should I add an intranasal corticosteroid spray? Or the patient, if you started the patient on an intranasal corticosteroid spray, can I go down? In a patient who is already treated, in this particular patient, we are looking at a treated patient, but the patient is still problematic, then again, you may want to reevaluate. If you started in again with just monotherapy, then therefore you need to step up, okay? You reevaluate again the patient, and then you can either step up or step down. Again, it is a very patient-centered approach, okay? Now, what are the more commonly used medications for your patients with allergic rhinitis? So 2023 guidelines tell us that new generation rather than your first generation antihistamines. You have your intranasal steroids, of course, your intranasal saline. Some patients will not want to take something oral, so we do have available intranasal antihistamines plus your steroid, okay? And in properly selected patients, you have your immunotherapy, okay? Strong recommendations against oral decongestants monotherapy, which a lot of the patients do, and of course your oral steroids. So again, this particular patient was referred by Dr. Pichi because the patient was very problematic. We know that patients with rhinitis alone, without any other concurrent conditions, that occurs in about 70 to 80% of your patient. But about 20 to 30% of your patients will not just have allergic rhinitis, but they will also have asthma, as in the case of Doctora's patient referred to us. But if you take a look at the patients with just asthma alone, a lot of them will have more compared to the patients with just rhinitis alone. We'll have more patients with the two conditions rather than if you just take a patient with allergic rhinitis alone. So what does that tell us? Well, number one, it tells us that patients who have the combination of your allergic rhinitis and your asthma are a particular subset of patients with allergic rhinitis. Similarly, it tells us that those patients who have allergic rhinitis alone, without your other comorbid or your multimorbid conditions, have specific pathways that are different from those with your combination, okay? So now, so what does that tell us about the common pathways of your patients with allergic rhinitis and with asthma? So there was this very large survey done in the European countries, and they said that rhinitis is an independent risk factor for asthma in your patients who are either allergic or non-allergic. How do we know again that there is a common pathway for both? If you will take a look at the biopsies of the nose or bronchial biopsies, you will notice that there is a similarity in the cellular and in the cytokine profiles, as you can see in terms of the T2 inflammation, so definitely related. Finally, if I were to challenge the nose and I will look at my bronchial pattern, again, you will see the same profile as when you challenge the lung, you will get the same profile as what you will see in the nose. So that means there seems to be really a common pathway for patients with both allergic rhinitis and with asthma. Okay. What are some of the theories why there is really such a close association for these patients? Number one is the concept of the epithelial barrier. We all have an epithelial barrier, whether it is in the skin, in the gut, and definitely in the nasal mucosa and your respiratory mucosa. That is your first line of, that is the first line of defense of the body. So once you have any break or leak in this particular epithelial barrier, and as you can see up here, you have all of those. The patient has allergens, the patient smokes, and we'll talk about the infection later on. But any break in the barrier definitely will, you see the, again, the flow and the process of inflammation that goes on in your patients with a break in the barrier, okay? So again, there can be what you call environmental risk factors and protective factors against having a break in your epithelial barrier, okay? So now, in terms of us being clinicians, does it matter if my patient just has allergic rhinitis alone versus my patient who's got both conditions? Yes, because they have a different profile, okay? Patients with both compared to patient with just allergic rhinitis will have a different profile. Let's take a look at the difference for your disease phenotype. Number one, these patients are more likely to be reactive to non-specific stimuli compared to those who just have allergic rhinitis. Maybe they just smell perfume and they're a lot more reactive, or they sneeze more compared to somebody with just allergic rhinitis. The capacity of the nose to humidify is going to be impaired, and so these are the patients who are more likely to have more severe nasal congestion and therefore nasal obstruction. The age of onset, it was seen that about 10 years earlier onset of either your asthma or your rhinitis in patients who are going to have both conditions, okay? And of course, a very strong family history is going to be predictive of your patients who are going to have the type, okay? All right, let's look at sensitization. This patient was very sensitized, okay? You had molds, cockroach, and then dog plus house dust mites, okay? All right, so we know that patients, from the data that comes in from Europe, New Zealand, Brazil, and China, we know that these patients have a greater sensitization. I'd like to share with you the results of the study we published, I think it was 2018. So we looked at Filipino patients. This was Luzon, Visayas, and Mindanao. They had to satisfy the clinical criteria for allergic rhinitis, and then they underwent skin testing. The most common for Filipinos is going to be, again, as you can see, the house dust mite, followed by your cockroach, and then your molds, okay? For the outdoor allergens, the most common is still going to be Bermuda, because I think this is the most common grass that we probably use in our homes and in the workplace. What is important to see is that 97% of our Filipino patients exhibited polysensitization, similar to what has been reported in other countries, okay? Now, when we looked at the comorbid or the multimorbid conditions that these patients had, look at it, 12%, that's a lot, had more than one associated comorbid disease, meaning that, did I do something? The slide looks different, sorry. Ay, nawala. So anyway, if you take a look, nawala yung slide. Okay, but anyway, if you take a look at the, it will be the next slide. Again, if you take a look, the most common is your urticaria followed by your dermatitis, then asthma, okay? So this particular patient actually had more than that, because here, asthma plus urticaria, asthma plus dermatitis will be the most common combination. These are patients already with allergic rhinitis, huh? Okay, one patient had 3, asthma, urticaria, rhinosinusitis. This patient has actually more than that, Doctora, because your patient also has food allergy aside from these 3 conditions, okay? So now, again, how does it affect the patient in terms of the clinical significance? We know that the greater the number of sensitizations, then this is going to be predictive of having your dual multimorbidity. We know that the symptoms are going to be more severe, specifically your nasal obstruction, your sneezing, and your watery rhinorrhea. And then if you take a look at the inflammatory cells, again, mast cells and eosinophils, as was proven in this patient, are going to be more. We know that the symptom control in patients are going to be poorer, okay? And that is the reason why they have unscheduled OPD visits, as you can see in this particular patient, ER and possibly hospital admissions. We had another study that looked at the control among patients with allergic rhinitis. 20% of them were poorly controlled, and therefore you may want to take a look at a referral to your specialist, okay? So, what would be the impact of having a patient with both? Number one, they will have more severe symptoms. They have poorer control with your oral antihistamines and nasal steroids. They tend to use more co-medications, and really the use of co-medication is associated with uncontrolled rhinitis. So how would I manage this patient? This is a patient who's very polysensitized. Patient has multi-organ involvement. I do not think monotherapy, for example, as an oral antihistamine would be sufficient. Definitely, this patient needs some form of intranasal steroids. In a few seconds, we'll talk about another reason for that. But more importantly, this patient is definitely a candidate for immunotherapy, okay? All right, so the next thing I'd like to know, does our patient have chronic rhinosinusitis? How do we know, again, that a patient has chronic rhinosinusitis? Not in particularly this patient. You need to have both your subjective parameters and your objective parameters. Remember, you must have 2 or more that will last for greater than 12 weeks. That makes it chronic. Anterior-posterior rhinorrhea, nasal congestion blockage, anosmia, hyposmia, and of course, the facial pressure and pain. Objective, CT scan, we scope our patients, and then we do some scoring system in ENT, okay? Again, what is the significance of this particular patient? This is a patient who had sinus surgery at the age of 7 and 28. 7 is a little, that's very early. We're rarely that aggressive in the young patient. So that means this patient must have had significantly severe disease, okay? So, what does it mean? Well, again, if you take a look at the link of your patients with nasal polyposis and asthma, they can have late onset asthma. IG expression, usually it's polyclonal. Again, the immune profile is T2. And the pathology is, in this particular patients, especially if you have infection, your Staph aureus is associated with severe asthma. So if that is the pathology in your patients with chronic rhinosinusitis, these are the patients who are at risk for having severe asthma, okay? Now, there are 2 studies in the Philippines that looked at the type of nasal polyps, whether they're neutrophilic or eosinophilic, because in most countries, it's eosinophilic. We do have eosinophilic, so that changes the way we manage the patient perioperatively and post-operatively, but if you do a survey, it's probably 50-50. You probably have patients with neutrophilic polyps versus patients with eosinophilic polyps. Unfortunately, in your patients with chronic rhinosinusitis with nasal polyposis, medical management treatment options are very limited. You start with your intranasal corticosteroids, and then you have your saline irrigation. Your intranasal corticosteroids will decrease the size of the polyps for small ones only, small polyps, mga grade 1, maximum of grade 2. They improve the symptoms, and then, of course, improves quality of life. They can breathe better. Your oral corticosteroids will do the same, but then, of course, we have to be careful with them. Antibiotics, especially macrolides, in your patients with acute exacerbations with an infection will definitely help. But the studies regarding its efficacy are not that great, all right? So significant disease or failure of medical therapy, surgical option, and of course, in patients with refractory recurrent disease, surgery, intranasal corticosteroids, and monoclonal antibodies are going to be necessary. How would I manage this patient? This patient needs to be scoped again because the patient may have smaller polyps. I mean, if you've had twice, maybe the patient doesn't have very good control. And again, I would definitely look at this patient again. And maybe that is one of the reasons why you don't have very good control. So with that, Doctora, I think, I hope I helped your patient.
Thank you very much for the consultation. So we have had one referral to ENT because of the other treatable traits that our patient manifested with. This is the kind of patient that's going to make you call on everybody because he has so many comorbid diseases. So let's take a look at what else he has and what else we have to figure out. The patient has been on several courses of oral steroids. He has also a history of Mallory-Weiss stare, for which he would self-medicate, for which he would take omeprazole, and then every once in a while he would self-medicate also with omeprazole because he claims to have gastric ulcer also. The patient's BMI is quite high, it's 31.14, and his abdomen is very globular. And so these could be some of the factors that we have to consider in the overall management of this particular patient. And so, being the responsible doctor that I am, I referred the patient for further management. So may we call now on Dr. Geraldine to give us her insights on the other treatable traits of asthma, this time concerning the gastrointestinal system.
Thank you for referring, Doctora. So Dr. Pichi already mentioned some of the clues. So are GERD and obesity treatable traits in this case? So these are the points in the history and examination that would make us think if the patient has concomitant GERD or is his obesity complicating his asthma. So he has poor asthma control, your atypical GERD symptoms which may present with chronic cough and chest tightness, his use of asthmatic medications, particularly your oral steroids, your history of Mallory-Weiss stare, which is not really a diagnosis of GERD, but rather GERD is a risk factor for Mallory-Weiss tears. So Mallory-Weiss tears are tears, mucosal tears in your lower esophageal sphincter. So that's your gastroesophageal junction. And this is also the asthma his symptoms might be predisposing him to that because chronic coughing, yung forceful coughing can actually cause Mallory-Weiss tears. So as well as his smoking history and his elevated BMI. So let's go through GERD first. So, well, we receive a lot of patients with concomitant GERD and asthma, and also our GERD patients would present more often with asthmatic symptoms compared to those who don't have. So, GE reflux is actually common among patients with asthma, and prevalence of gastroesophageal reflux symptoms among patients with asthma vary from 30 to 90% depending on which study you look at. Conversely, respiratory symptoms, including symptoms associated with asthma, are increased among GERD patients. So this is like a table of all the studies. So one of the largest ones was a systematic review of 28 epidemiological studies in 2007, wherein they found that the prevalence of GERD symptoms are more common, or 59%, compared to those who are non-asthmatic. So there are several mechanisms that are proposed to contribute to this relationship. So we have your reflux theory, or a direct mechanism wherein your microaspiration of your gastric contents cause your bronchoconstriction. And then you have your indirect cause, your reflex theory, because the esophagus and your bronchial tree, they share the same embryologic origin. So when the distal esophagus is exposed to acid, when it's refluxing there, it causes, via a vagal mechanism, it causes bronchoconstriction. Okay, so that's GERD causing asthma. Now, asthma causing GERD, my apologies, I should be nearer. Okay, so your asthma causing GERD, on the other hand, so you have your coughing, increased coughing, and your hyperinflation causing negative intrathoracic pressure or increased abdominal pressure, which pushes your acid upwards. And you have your use of your asthma medications. Your beta-adrenergic agonist can lower your lower esophageal sphincter pressure, causing GERD, and your oral steroids or glucocorticoids increasing your acid contact time. And this may contribute to your presence of your GERDs or development of GERD.
You point on this. You point.
Oh, sorry. Mali. Okay, there we go. So when we are presented, or when we wrong. Okay, when a patient comes to the clinic with GERD symptoms, we, of course, as with Dr. Cleto's recommendation, detailed medical history is very important. So for us to differentiate whether is this asthma or is this GERD or is this both. So, and if we find other symptoms like throat discomfort, we refer to our friendly ENT. So, and we evaluate based on the physical examination findings. There is no specific physical examination finding for GERD. It's a clinical diagnosis. We can't see the sphincter looking at the patient. So, and then we manage it, how we approach the patient depends on whether he has the typical GERD symptoms. So what are your typical GERD symptoms? Your heartburn, so your burning sensation, and then your regurgitations or your reflux of your previously ingested food or acid. So actually asthma, chronic cough falls under your atypical GERD symptoms. And then how we approach it depends on the absence or presence of these ones. No? So you have your typical, and those with only atypical symptoms. So let's first go through those with both typical and atypical GERD symptoms. So these patients actually would benefit with from a trial of PPI therapy twice a day for 8 to 12 weeks. So those whose symptoms improve are managed as GERD. And a successful trial, you can actually monitor your symptoms. So if there is an improvement or a peak expiratory flow rate by 20%, a 20% decrease in oral glucocorticoid use, or an improvement in your asthma symptoms, then we would consider this patient with concomitant GERD asthma and asthma. So those who did not improve, or you find yourself switching to several PPIs, actually in the latest guidelines here in ACG, they don't recommend switching more than once PPI, because if they don't respond, they probably are not going to respond later on. So these patients would actually benefit from pH reflux monitoring of medications. No? So we try, because they're not responding anyway, you can talk to them and stop your PPIs. No? And then you refer for pH monitoring. And those who are detected to have abnormal or to have an objective finding of reflux would be treated as GERD, and you start PPIs for those patients. So these are your pH monitoring devices. So this is 2 types. So you have your catheter type pH monitoring. It's available in some centers here, but not as very accessible as your endoscopy. But it is available. And you have your capsule type pH monitoring. So for your catheter type, there's a probe that goes up to the LES, or the gastroesophageal junction, and it detects changes in pH and this would diagnose your pH, your reflux monitoring. It's ambulatory, so it depends on the patient's activity also. You can detect the number of reflux episodes. And then a special one would be your impedance monitoring, wherein instead of just the distal catheter having the sensor, there are different sensors throughout the length. And this doesn't just check for the pH, but also any non-acidic reflux, which can also contribute to your symptoms. So this is quite specialized already. So now for our patient who only has atypical symptoms. So personally, I would, this patient would benefit going straight to reflux monitoring before starting PPIs. So that we can, tailor fit his treatment depending on his symptoms. But, the more common test, that we get referrals for, when do we do endoscopy? This is actually more accessible. And the patient actually would benefit for upper and GI endoscopy upon first consult. So what are your indications? So if there is no or incomplete response to your trial of PPIs, or even the worsen your symptoms, even the presence of your alarm symptoms, so you have your anemia, weight loss, long-standing GERD symptoms, or in your presence of dysphagia or dinophagia, or if the patient has risk factors for Barrett's esophagus, which is a precursor to adenocarcinoma. So this is actually one of the reasons why I would do endoscopy in this case, because of the patient's presence of obesity, the male sex, tobacco use, or if the patient has family history of cancer. So what do we usually see in the endoscopy for patients with GERD? So GERD is actually confirmed if you find grade C and D reflux esophagitis based on the Los Angeles classification. Grade A and B, so you can still have GERD even if you have the mild esophagitis on EGD. And we usually see, actually most patients with GERD would have normal EGD findings, especially those who are already on PPIs. It's just that it's because PPIs just do such a good job in healing the esophagitis. So for us to diagnose, we would actually prefer the patients off PPIs if their symptoms allow it. And then I mentioned Barrett's esophagus, wherein GERD is a major risk factor. So this is a precursor to adenocarcinoma, and it's very important to catch this in this patient population because it's a preventable cancer. No? So we do biopsies to confirm dysplasia and metaplasia and put this patient on PPIs if this is confirmed. So as I mentioned, pharmacologic acid suppression with PPIs is your mainstay of pharmacologic therapy. And we consider empiric PPI treatment in patients who are presenting with typical GERD symptoms and those with diagnosed with a pathologic reflux on pH monitoring. We also have our non-PPI treatments, so your alginate-containing antacids, your antacids, that's our rescue therapy, and your H2R antagonists, which we usually add on to PPIs, usually for nocturnal symptoms. So part and parcel with GERD management is actually your diet and lifestyle changes. So these are actually your recommendations. And PPIs is not enough. So you have to take the time to educate your patients regarding this. So weight loss. So whenever you have increased adiposity, it pushes on the abdomen, pushes and pushes the acid up the esophagus. You elevate your sleeping position also matters. You elevate your head of bed by a wedge or pillows, prop yourself up 30 to 45 degrees while lying on a left lateral decubitus position. So you're asking gravity's help for this in this case. The avoidance of trigger foods. So this is actually a case-to-case basis. There's no umbrella trigger food that you should avoid, and it varies per patient. And you can actually ask your patient, what types of food would actually make your reflux worse, and you ask them to avoid it. You avoid meals within 2 to 3 hours from bedtime. Gastric emptying time is normally around 4 hours, so you wait for the food to go down before lying down. And of course, smoking and alcohol cessation. So smoking is a risk factor for GERD. Alcohol is a direct noxious stimuli in your esophagus, and it increases your risk for GERD attacks. Okay. So there is actually a surgical endoscopic management that you offer for patients whose response to PPIs are very marginal. But in patients who do not present with the typical GERD symptoms, the response is actually not as predictable. So you only offer this for highly selected patients. So those who have a prior response to PPI, so far you're kind of sure that the patient has GERD. Those who have the typical GERD symptoms, and because it confirms your diagnosis, or those who can't take PPIs. So it's either they are unwilling to take it for a long time because of the side effects, although it's quite rare, those who are intolerant to it, or those with contraindications. So the picture there is a Nissen fundiplication surgery. So now we go to address the other treatable trait as evidenced by the patient's elevated BMI and globular abdomen, obesity. So there's such a thing as obesity-related asthma. I'm sure everyone is aware. It's a type of severe asthma with a blunted response to your traditional asthma treatments. So they have worse asthma control. They have more frequent use of rescue therapies, higher dose of steroids, both oral and inhaled. And they have more risk for hospitalizations from your exacerbations. As I mentioned, they're also more likely to report GERD and sleep disturbance. So there are several pathologic mechanisms of how GERD contributes to asthma severity and control. So first, you have your mechanical forces. Just like GERD, you increase adiposity and reduces your lung compliance. There's also such a thing as, I've read that you see it in those with childhood asthma and obesity. There's the dysynapsis, so their bronchioles are actually smaller with respect to their lung volume. And then the state of obesity puts your body in a pro-inflammatory, a low-grade inflammation because of your adipokines, pro-inflammatory cytokines from your adipocytes. Your metabolic dysregulations or insulin resistance. So they found that those with metabolic syndrome or diseases related to it have a higher risk or poorer asthma control regardless of their BMI. Also, high-fat diet. They found that high-fat diet or high in unsaturated fats put you at a higher risk of higher state of inflammation in your airways, and this leads to poor asthma control. So all this work together in worsening your asthma. So our patient falls under one of the two obesity-associated asthma phenotypes. So he has childhood asthma, wherein with elevated markers of allergic inflammation. So it's important. So he falls under the early onset allergic asthma, which is related to atopy. It's important to know and to educate your patient that even if he undergoes weight loss, the control of asthma is still as important because the asthma doesn't really go away just with weight loss, as opposed to your late onset non-allergic asthma phenotype, which is asthma consequent to obesity. So in evaluating patients with asthma and concomitant obesity, it's always important to evaluate for comorbid conditions. So you have your GERD, you evaluate for obstructive sleep apnea, you work up and manage your metabolic syndrome that the patient already has impaired fasting glucose and elevated HbA1c. You see also if the patient has concomitant mental health issues. And I failed to mention that actually your anxiety and depression can also exacerbate your GERD. No? So parang mas nafe-feel nila yung symptoms nila whenever they're under stress, no? If they're anxious. And I actually refer my patients sometimes to psychiatry just to manage this. And it improves their GERD symptoms actually. And of course, you delve into the smoking history and other potential worsening factors. So in managing obesity-related asthma is actually a multimodal approach. The mainstay of therapy is still optimizing your asthma medications with the expectations that they may not respond as well as their non-obese counterparts. We also aim for weight loss. You try the different interventions. We'll go through it one by one later. And without forgetting your comorbid conditions, no? So you just don't target one. I think that's the whole theme of this symposium. So I mentioned pahapyaw, the diet and exercise. So this is a nice graphic for this. So they found that high fat, low fiber diet rather, increases your airway inflammation with increased sputum neutrophils and a decrease, and it blunts your bronchodilator response. And if you have a diet high in fruits and vegetables, they actually found that this decreases their airway inflammation and improves their asthma control. Now, the patient is very hesitant about exercising, no? But increasing your physical activity and incorporating exercise in your lifestyle would actually improve your lung function, increase your exercise capacity if you push through it, with improved inflammation markers and leading to better asthma control. So diet and exercise work together with the goal of weight loss to target your obesity. Now, what does weight loss have to do with your asthma control? So they found that weight loss can actually improve airway inflammation and asthma control, and even minimal weight loss has benefit. So in terms of the lung mechanics, the improvement here, they see this in weight loss of more than 5% or more. And then they found that in patients who are enrolled in weight loss intervention programs, a combined approach, for example, controlled diet therapy plus a structured exercise program, would work better than just one modality alone, right? So in this patient, I didn't write it in the slides, but one of his triggers is actually exercise, so that's why he's very hesitant. He's not moving around a lot. So how do we manage this? So this patient would actually benefit from enrolling in a structured exercise program. So you don't tell him now, okay, just walk 60 minutes a day, because that will just make him be hesitant and not move if his symptoms get worse. So a structured exercise program, so you work with an expert, no? Usually those who have a good experience with also lung rehab, so that you start slow, because any sort of physical activity will have benefit, and you have to educate the patient that it's not an overnight thing. It has to be a slow and continuous process. So now we go to your pharmacologic options. So there is currently no FDA-approved medication specifically indicated for obesity-associated asthma. But they found that obesity medications promoting weight loss would actually, they found that there is some benefit. So these are just some of the ongoing studies exploring that. So you have your very popular GLP-1 agonists. So there's actually a recent trial that they found that it actually compared to, this is among the type 2 DM patients and obesity with asthma. So they found that they actually have lower exacerbations among those diabetic patients who are on another diabetes medication. So they just compared those who, depending on what medication you are taking for diabetes. And I think there are several studies that show that GLP-1 agonists have lower your airway inflammation also, but there's no fixed recommendation in asthma in particular as of yet. So you also have your metformin, but this is in mouse models, and your statin therapy, which they found that it reduces your exacerbations but has no effect on lung function. Now you have your nutraceuticals, your L-citrulline, so it's a modulator of nitric oxide metabolism. They found that increases control. And your fish oil, which targets your low-grade inflammation, unfortunately has no significant effect on asthma control and lung function. So finally, in those patients who were in lifestyle and pharmacologic interventions are not effective enough, and we actually recommend this for patients with a BMI of 35 and above, plus severe asthma, because it's a comorbidity already. We offer bypass surgery. So you have your bariatric surgeries, rather. So you have your gastric bands, your AGB, your gastric bypass, or your sleeve gastrectomy. So it's already available in some centers. They found that those who undergo bariatric surgery have improved asthma symptoms baseline, reduced inflammatory markers, and reduced hospitalizations from exacerbations up to 1 year post-op, with improved lung functions. And with all these studies exploring that, they just found that the maintenance of weight loss is actually your best indicator of whether your asthma will be controlled post-bariatric surgery, or if you undergo all the other weight loss interventions. So, So how would I manage this patient? So, of course, I would refer to myself for upper GI endoscopy for the BE risk, or if ambulatory reflux monitoring is not available. So you just want an objective evidence for reflux before considering PPI treatment. And of course, emphasize the importance of diet and lifestyle modifications, both for your reflux and obesity, and of course, your smoking cessation. So thank you for referring, Doctora, and thank you very much.
Thank you, thank you. By the way, I also refer this patient to Dr. Geraldine because not just for the obesity, the weight loss, and for the possible GERD, she's also a clinical nutritionist. And so she will be able to give prescriptions on the proper diet of the patient. We just have to find an expert on exercise. Okay, kulang. Sana nag-invite ako. Okay. So let's go to the other problems that this patient has. Madami talaga. This time, the patient claims he has good adherence. Dr. House is not my idol, no? But he already said in his shows, everybody lies. So whenever a patient tells you something, you have to always keep it in mind that maybe he's not telling you the whitest of truths, but a little bit on the gray side. So good adherence always with quotation marks. He said also that he used to smoke more than he does now. Again, grain of salt. Madaming experience si Dr. Jannel. Okay? And then finally, when we did the neuro exam, in the mental status exam, he seemed to have a depressed mood. And definitely this is something that we're going to have to target. And more of us are more open now to this comorbid disease, which may involve also the mental status, the emotional state of the patient. And this is why we referred our patient to Dr. Jannel, to be able to deal with his anxiety, depression, as well as a little bit on the smoking. All right, Dr. Jannel. Point it here. Okay. Not here, point it there. Okay. There, the laptop. There.
All right. Can you hear me?
Thank you.
Hello, can you hear me? Okay, hello, good afternoon, good morning. All right, so let's talk about this patient in terms of his treatment adherence. So we don't just step up, no, with our treatment. We try to check first regarding the adherence to the treatment. As what Dr. said, patient claims to have good adherence to recommended treatment. So what is good adherence to the treatment in the first place? We need the patient to be active, no? This is a voluntary behavior from him, and it's a collaborative engagement of the patient with you. Okay? So adherence actually differs from what we call compliance, because compliance implies a passive conforming of the patient to the doctor. Okay? So it has to have acceptance from the patient, persistence of taking the medications, and of course, the proper execution of the prescribed medication regimen. Oops. All right. Okay. So, studies show that patients, even their caregivers, can vastly overestimate their treatment adherence. Okay? So this is likely due to a combination of course, it's difficult to recall the past weeks, the past months, and they might be embarrassed to tell you that they're not compliant in the first place. Okay? So what is optimal adherence? It is often defined by more than 80% medication usage. So that's actually high, 80%. If it's more than 80%, the patient is the patient is adherent. So what is the difference between primary non-adherence and secondary non-adherence? Primary non-adherence is the rate at which the patient goes to your clinic and asks for the prescriptions. Secondary non-adherence is when the patient goes home and takes the medications. Okay? Research shows that even after an asthma exacerbation-related hospitalization, admit na, no, yung patient, adherence rates in high-risk children have been shown to be as low as 34 to 40%. Okay? So what are the factors to treatment non-adherence? Of course, we know that asthma can be diagnosed early. No? So as children, they're reliant on their parents, their caregivers, to give them their medicine. Okay? When they become adults, they go through many things, and of course, they have to be responsible for their medications, but they have competing priorities in life. Okay? So what are the factors? Negative health beliefs, including anxiety or concerns about medication use. Maybe you can ask your patient, what are your thoughts about your medication? They might actually tell you, I'm afraid of using corticosteroids for a long time. So this might require explanation from you. Okay? And asthma medications, again, require specific techniques to be delivered. Some would miss their appointments, and of course, the high medication costs. Okay? And we have to see if the patient or their caregivers are in distress or even depressed, because this might lower their motivation to take their medications or give them medications. Okay? So this is something maybe that you can check out. This is the Adherence to Asthma Medication Questionnaire, or AAMQ. So you can give this to the patients, 13 questions. And as you can see from the questions, they're very specific to asthma. And it does not just tell you how adherent the patient is, but also the reasons why the patient has difficulty consistently taking the medication. You can also use the brief adherence rating scale, very few questions. And if you really don't have time, you can just ask the patient from 0 to 100 or 0 to 10, how adherent are you to your medications? Okay? So how can we improve treatment adherence? Of course, asthma education is very important. It can even help if you give flyers or direct them to the right websites to check out and learn more about their asthma. Okay? Self-monitoring of medication using diaries or cell phone alarms. And now we have cell phone apps that can help, and these apps utilize gamification and incentive strategies. Okay? And as they go to your clinic, feedback on the medication taking behavior. Okay? We can ask them to, make taking the medications a healthy habit for them, because of course this will benefit them in the long run. Increasing communication between you and the patient or their family. And we have to ask them, did you understand what we talked about? Are there any questions? Okay? And you can even talk about any barriers that might be interfering with their adherence. So these are just some of the phone apps that you can try to check out. Okay? And this one, the last one, is actually for kids. Okay? There. So let's go to this patient that you were talking about. Okay? So in the past months, of course, he has been having asthma symptoms, but it says here that it occurs multiple times a day, and the asthma exacerbation would resolve with nebulization. Okay? And of course, we got from the history that he has depressed mood. We don't automatically say that he's depressed. Okay? Maybe he's depressed that day. We don't know, but we have to check. Okay? Some things that we would like to get more additional information. ROS, again, the recent weight loss or gain, digestive problems, the appetite, sleep, energy level, and concentrations. Okay? And it's very important to also check the thyroid, okay? Because there are thyroid conditions that can cause depression and anxiety. And even the ECG, many patients complain of palpitations, but we have to first exclude cardiac conditions. So 1/4 of people with asthma believe that emotions and stress are among their top asthma triggers. Okay? So with this patient, it's a simple question of, how are you doing right now? How stressed out are you? Okay? O kaya the question of, are you encountering any personal difficulties right now? Okay? Since stressful life episodes have been demonstrated to exacerbate asthma. Okay? We know that airway and immune system function are susceptible to direct psychological influences through the nervous system, and endocrine pathway. So the neurotransmitters, and of course, our HPA axis. Okay? Vagal excitation and hyperventilation associated with anxiety or depression leads to bronchoconstriction that is clinically significant. So anxiety and depression are actually common in asthma patients. At least 1/3 of patients with persistent, even chronic asthma experience symptoms of anxiety or depression. Okay? And they might also be diagnosed or have other anxiety conditions such as PTSD, social phobia, and even alcohol use disorder. And there are asthma medications that can induce anxiety. No? We know this. And corticosteroids can also affect the mood. Okay? So the patient has depression, asthma already. If he has anxiety or depression, this may really lead to poor asthma outcomes. Okay? Frequent emergency visits, severe asthma symptoms, and higher use of the medications, even non-adherence to therapy. Okay? If the patient has anxiety or depression, there might also be a possibility of inaccurate perception of their symptoms or their asthma symptoms. For example, for those who are very anxious, they tend to overestimate their symptoms. For depression, in depressed patients, they usually have a lower pain tolerance and they have many aches and pains. Okay? So patients with severe and prednisone-dependent asthma had more significant depressive and anxiety symptoms, of course, because of the prolonged course of their condition. And patients with depression may have higher body mass index. Okay? So some predictors of anxiety and depression in asthma: late asthma diagnosis, other medical comorbidities, and female gender, most probably because of our hormones, okay? And the many responsibilities that we have. Okay? So how do we know if this patient has depression? These are just the red flags. Aside from the depressed mood, which he experiences most of the day, almost every day, and lasting for more than 2 weeks, we can also look for irritability, especially in children and the elderly. And this is also a red flag, anhedonia. It's like, I don't anymore enjoy. I don't anymore feel pleasure about when I do my hobbies or any previous things, previous activities that he enjoyed before. And these are just some of the symptoms of depression. And we can see there's difficulty concentrating. So we can ask the patient, how are you at work? Are you having difficulty concentrating? How do you feel when you're at work? Especially your self-esteem. Okay? And of course, in depression, very important to ask for feelings of hopelessness, thoughts of self-harm, and difficulty sleeping, very much present in depression. For some, they have difficulty falling asleep or maintaining sleep, but there are also some who are depressed who like sleeping a lot. Okay? So maybe an escape from the world. There's also a decrease in appetite, or the opposite, excessive eating or even binging, since of course food can be comforting. Okay? How about panic disorder? Okay? So if the patient, you can ask about recurrent panic attacks, and if there are, you can already diagnose with panic disorder. There is also persistent concerns about additional attacks and worry about the implication of the attack. You might hear from the patient, I'm worried that I'm going to have a heart attack. Okay? Some may have agoraphobia, which means they don't want to go out of the house, go into public places, many crowd, because they fear that if they have a panic attack, there's no way to escape or help might be unavailable. So these are just some of the symptoms of a panic attack. And as you can see, there really are similarities between an asthma attack and a panic attack, especially the shortness of breath, the chest discomfort, even the palpitations. Okay? So how do we tell? The girls go there. How do we tell if it's a panic attack or an asthma attack? Okay? If it's a panic attack, of course, the cluster of symptoms, so they might complain or they might say that they have cold, clammy, extremities, dizziness, tremors, and these symptoms reflect a panic fear and hyperventilation hypocapnia. Okay? And of course, triggered by stress or anxiety, rising in intensity within minutes, and it's not very, it doesn't really occur very long. No? Maybe at the most it's 20, 30 minutes, but of course not more than 1 hour. Okay? And of course, there's a catastrophizing of the symptoms. If it's a panic attack, you can see the wheezing, mucus congestion, and coughing. And of course, symptoms last longer and is really recurrent. No? Triggered by allergens, exercise or stress, and for this patient, relieved with medications. Now, for patients who are asthmatic with panic disorder, they may report higher levels of subjective stress, which may not be proportional to the severity of the asthma attack. Okay? So it's not just panic disorder. There might be a possibility of what you call generalized anxiety disorder, and you'll be surprised that many people have this. So it's excessive anxiety and worry, and the worry is difficult to control. It may affect sleep, muscle tensions in the body, makes you irritable, no, and very restless. Okay, so it's what we call the worry wart. Okay, sometimes you're worrying so much you can't sleep. All right. So what can help us screen this patient for depression? You can use the patient health questionnaire. It's just 9 questions. Okay, you can have this at your clinic, especially not just for asthma patients, but for those who you're considering might have depression. And the cutoff score is 10. Higher scores might make you think that this patient might benefit from referral to us, psychiatrists. Okay. For generalized anxiety disorder, we have GAD 7, and the cutoff score, again, is 10. And again, if high scores, try to refer to us. Okay? Hospital anxiety and depression scales have both anxiety and depressive symptoms in one scale. Okay? Very easy also to answer. So, if ever this patient really has depression, no? parang hindi siya masyado on the panic disorder. But we can also try to see if the patient has GAD. So some questions would be, again, what are you going through right now? Okay? So the first line of treatment in depression and anxiety are antidepressants, the SSRI and SNRI. And there are also novel antidepressants already present in the market that doesn't belong to these 2 categories. Okay? And of course, we give benzodiazepine, alprazolam, clonazepam, sometimes diazepam, okay? And I'd like to highlight that these medications are helpful at the beginning of the treatment, but definitely they are not maintenance medications, okay? And for a patient who has panic disorder or panic attacks, avoid propranolol because we do give this in panic attack because propranolol may lead to bronchoconstriction. So it's not just the medications, but the management we give is more of a biopsychosocial, even spiritual approach if it helps the patient. Okay? So for the psychological, aside from supportive therapy, we have cognitive behavior therapy. Mindfulness is actually very popular nowadays and is also evidence-based. Okay? For the social, we ask this patient, who do you live with? Is it just your dog? Okay? How's your support system going? Okay? Because of course, in order for the, in order for the patient to have less of the exacerbations, we try to increase the immune system. Okay? And oxytocin is very important. Okay? And of course, the lifestyle. Okay, now we go to smoking and asthma. Since this patient said he's a smoker, smoked 5 to 10 cigarettes per day since age 17, but has since reduced to 1 to 2 cigarettes per day since 5 years ago. And again, hopefully this is true, but we really need to recheck if it's accurate, especially during those times when the patient is stressed out. No? The smoking might also increase. So approximately 20% of asthmatics currently smoke. And of course, we know that smoking is associated with more severe asthma symptoms, higher corticosteroid use, inhaler overabuse, and inhaler non-adherence. Okay. So how do we help a patient who's smoking and who wants to stop smoking? Very important, of course, is the motivation. Is the patient ready to quit? Because even if you give these treatments and there's no motivation, ma-frustrate lang kayo. Okay? So nicotine replacement therapies include patch, oral forms. Varenicline is an oral medication, a partial nicotine receptor agonist. It's already available in the market. Okay. E-cigarettes are not currently approved by the FDA as a quick smoking aid. Okay. Of course, referral for psychotherapies can help, especially motivational interviewing and CBT. Smoking cessation mobile applications are also available. So you can try to tell them, try to download this app and see how this can help you. And when they go to your clinic and does spirometry, no, or if they feel that they're better, if they're reducing their smoking, this can really be a motivator for them to eventually stop smoking.
Thank you very much. Thank you very much. So you see that we have gone through the different treatable traits in asthma, but can we apply this in the primary care setting? This was our third learning objective for this particular session. And if you take a look at GINA and the guidelines in GINA, this particular part, the treatable traits in asthma, can be managed in the primary care setting. And we encourage all the primary care physicians to take a more active role in doing this part of the asthma management. So as you can see here in this particular slide, we have already confirmed the by the way, please always refer for spirometry. We would like to be able to confirm the diagnosis of asthma before we start treatment. Spirometry is available in very many institutions. We confirm through spirometry and we look for the other factors that we can manage in the primary care setting. And for this particular session, we looked at improving the inhaler technique or checking. Please make this always a part of your 10 commandments in treatment of asthma. Number 1, check on the inhaler technique, because just correcting the incorrect technique may already be very, very beneficial to your patient. We also looked at adherence. Patients will tell you, yes, I adhere to my medications, but you try to find out if this is really true. We looked at the other comorbid diseases. We referred to gastroenterology as well as to ENT for the possible comorbid diseases. That could also affect asthma control. Look for factors at home, the dog. That's my worry, the dog. And at work also. And then try to see where you could help in terms of trying to decrease the triggers to your asthma symptoms. This was not discussed, but it's very important. The patient has been having multiple episodes of symptoms in a day, and he always nebulizes with salbutamol. Not good. So maybe we can ask him to use just one inhaler containing your steroid as well as your formoterol for both the maintenance as well as reliever therapy. And we looked at the possibility of the mental health of the individual in increasing the symptoms of asthma. When he has asthma attacks, could it be panic attacks? So these are all the different factors that we should consider whenever we assess a patient who does not seem to be controlled with the current medication is being given. So what do? We optimize the treatment. Non-pharmacologic interventions also, we treat the comorbidities, and then if your patient still does not seem to be responding to that, or really at any time during your care of the asthma patient, always consider referring the patient to a specialist so that we can be able to streamline the treatment of our patients with asthma. And so we have referred the patient to 3 other specializations aside from pulmonary medicine. We'd like to ask for take-home messages. First from ENT.
So definitely confirmatory diagnosis, you need to have clinical symptoms, you need to have a history of exposure, and finally evidence of sensitization. Refer the patient to a specialist in patients who don't respond to medical therapy or who have a questionable diagnosis. Again, you need to assess severity and frequency of the disease. The medications, I think you're all aware of. Please always look at the possibility this is a patient who needs immunotherapy. And I think finally, in your patients with chronic rhinosinusitis, again, you want to look at subjective and objective parameters. Please refer your patients with chronic rhinosinusitis. They're very difficult to manage. Medical options will work, but a lot of times you need to really do a very extensive workup. This particular patient, I think, is going to be a patient definitely at risk for recurrence. So maybe more than just medical management, this is a patient who's going to need another surgical intervention.
Thank you very much, Doctora. Now we also took a look at the other comorbidities involving the gastrointestinal tract. Can we ask for some take-home messages from you?
Right. So for the GI aspect, so these are the clues you look for in considering if your asthmatic patient has GERD, so the presence of your typical GERD symptoms, or if your GERD symptoms are triggered by your asthma symptoms are triggered by your GERD triggers, so your food. And if your GERD symptoms are actually relieved by your asthma medication. So these are some things that you can ask your patient. You consider PPI trial empirically for around 8 to 12 weeks in patients with asthma with your typical GERD symptoms and monitor further improvement. Consider referral for further workup, your endoscopy or pH monitoring if GERD is suspected in the absence of typical symptoms or failed empiric PPI. And you consider early GI referral in patients who present with alarm symptoms, as well as for those who have risk factors for Barrett's esophagus. Also, I failed to mention there's a disease entity that's increasingly being recognized in patients with atopy. So there's such a thing as eosinophilic esophagitis, and they present similarly as with GERD symptoms, and you do it with biopsy and would require different treatment. So. And then for obesity, obesity-associated asthma tends to be more severe and more resistant to your conventional asthma treatments. Workup, you shouldn't forget the other comorbidities and manage them accordingly. Treatment is multimodal. Diet, exercise is a very important part of the management. And consider pharmacologic and or surgical options for obesity in those wherein lifestyle modifications are insufficient. So thank you very much.
Thank you very much. And finally, we took a look also at the other treatable factors which were discussed by Jannel. Dr. Jannel, your key messages.
All right, so again, adherence to maintenance medication is often low and needs to be addressed, especially in asthma. Asthma education is essential and effective. Anxiety and depression are common in asthma patients, and treatment, of course, of these conditions can lead to better asthma outcomes. And in managing patients, we try to take a biopsychosocial approach. And of course, we try to also ask about their lifestyle, okay? And something maybe that you can try in your clinics, especially since the patients are just waiting outside, you can try to take advantage of rating scales, no? As what I showed you earlier, because of course, they're also simple to answer. Okay, and then when they go to you already, you kind of have a partial, understanding already of the patient. And of course, lastly, smoking cessation advice is important to all asthma patients who smoke.
Thank you very much. And then finally, the pulmonary traits, treatable traits in asthma, key messages. Please, always, 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 3 times capital letters. Okay? Check inhaler technique because the persistence of the symptoms of your patient could just be due to that. No? Airflow limitation could just be due to a wrong technique. For eosinophilic asthma, these are more for the specialist, so please do refer. If you see a lot of eosinophils in the CBC of your patient, of course, baka yas bulate. Okay. Number 1, the Philippines, bulate also. But you also can refer to the pulmonologist if he does have symptoms of asthma that do not seem to be controlled. For the infections, early detection and management, a good history taking and physical exam may help you immediately deal with infections. Of course, you would also like to prevent infections or vaccinations. Look into the environmental, occupational triggers, also in the house, no, the dog. And if the patient refers symptomatic, please do not hesitate to refer to the specialist. One thing also that can empower your patients, have them do an asthma action plan so that they know when they should increase or decrease their medications. Of course, always tell them that you are always available for them, but the peak flow monitoring will definitely help. So it's just not empowering ourselves, knowing when to refer to our friends. We are also empowering our patients so that he will be able to do management on his own. So I'd like to thank our specialists who have come here today. Dr. Cecilia Gretchen Navarro-Locsin, ENT, Dr. Geraldine Claire Floro-Lucero for gastroenterology, Dr. Jannel Gatlabayan-Cleto for psychiatry, and of course myself. Thank you to me. And we will be giving them certificates of appreciation to all of them for being a speaker on multidisciplinary discussion, treatable traits in asthma during the 43rd Annual CHEST Convention, March 6 at sa Shangri-La, Mandaluyong City, signed by our Madam President, Dr. Aileen Aniceto, Overall Chair, Dr. Virginia S. de los Reyes, and our Chair of the Scientific Committee, Dr. Albert B. Albay Jr. So thank you very much, everybody, for attending. Thank you again.